In an earlier video, we examined the question, how does communication heal in the doctor-patient encounter? Our answer to that question focused to a large extent on verbal communication, such as the exchange of information and patient education. In this video, we will examine the research on nonverbal communication in clinical encounters. Appropriate nonverbal communication behaviors can certainly come into play in information exchange. For example, patient and doctors alike use nonverbal cues to signal understanding of each other. However, when we think about such important communication functions as responding to emotions and empathizing with the patient, nonverbal communication must be considered. Allow me a few initial observations. First, nonverbal communication in the doctor-patient interaction is very important but understudied. It is remarkable just how little research has been carried out on this topic. Research in other contexts, such as personal relationships, politics, and the workplace, has shown that people rely extensively on nonverbal cues to find meaning in verbal statements, assess the emotional states of other people, and make judgments about their character and intentions. There's no reason to assume that things would be different in medical settings. It is time for a definition. A standard definition is that nonverbal behaviors refer to the behavior enacted in interaction that lacks linguistic content. Some nonverbal researchers distinguish between nonverbal behaviors that are unrelated to speech, such as eye gaze, gestures, and forward lean, and nonverbal behaviors that accompany the act of speech, such as the loudness and tone of one's voice. A final observation: nonverbal behaviors can shape impressions without conscious awareness. We can develop an impression about a person based, in part, on their nonverbal cues without being consciously aware of how those cues are affecting those impressions. We might say, I have a bad or good feeling about that person, without being able to articulate why. We might even call these impressions gut feelings or attribute them to intuition. Nonverbal behaviors and verbal communication, that is, our use of language, have three potential relationships with each other. First, nonverbal behaviors can substitute for language. When you lose 10 pounds on your diet and your doctor gives you the thumbs up sign, that gesture could easily be translated as good job. Second, nonverbal cues can reinforce what is being said through language. An example: a patient asks his doctor if it would be safe for him to go off his hypertension medication. The doctor responds with the word no, but loudly, no. The doctor is empathizing the negation that was expressed with words. Third, verbal and nonverbal communication can be in contradiction. This is fine if you are trying to be sarcastic. However, in clinical communication, clear communication is the goal. As such, nonverbal communication and verbal communication need to be aligned. In this example, a doctor is smiling while expressing concern. The smile weakens the message and is likely to confuse the patient. Earlier, I said that nonverbal communication is seriously understudied. Why is this so? First, privacy concerns can make it difficult to study nonverbal communication in doctor-patient visits. Most patients are agreeable to having their visits with their doctor audio taped, but if you were asked by researchers to allow them to videotape your visit, you might be hesitant. Very private things are done in the doctor-patient visit. Most patients would be too modest to allow such recording. Even if we told you that we would turn off the recorder during the physical examination part of the visit, you might be concerned about whether or not that might be done. Privacy concerns make the study of nonverbal behaviors challenging. Another difficulty is the logistics of nonverbal study. Let us assume that we could overcome the privacy concern I just mentioned. We would probably have a study involving dozens of doctors, each with his or her own examination room. We would need to have equipment put in each of those rooms. We would probably need to have multiple cameras to capture the behaviors of the doctor and the patient. These cameras would need to be coordinated. We would need an AV specialist nearby to make sure the visit was being recorded. Lots of equipment would be involved, lots of personnel too. This points to the third difficulty in studying nonverbal behavior in clinical visits: resources. Such research is expensive. We would need a huge grant to pull this off. Funds would be needed for equipment and for AV technicians. However, even more money would be needed to code the tapes, that is, to make observations and measurements of the nonverbal behaviors of the doctor and the patient. Another cost is time. Even if we have the funds, we would have to devote months, if not a couple of years, to analysis. It's not surprising that we have dozens of studies based on audio tapes of visits for every study that used video recordings. One thing that has become clear in the studies reported to date is that physician and patient gender affects patients' responses to their doctor's nonverbal behaviors. We will start at the beginning. Years of research in the social sciences demonstrates that men and women often communicate differently. There's no doubt about it. One caveat here, we're talking about differences in how men and women communicate in general. There are no doubt exceptions. Some men may communicate in a style that's more feminine. Some women may communicate in a more masculine style. Over the course of medical school training, differences in the male and female communication styles may grow smaller. However, they do not go away altogether. A full discussion of how men and women differ is beyond the scope of this video, but here are a few examples. Women tend to be more socio-emotional oriented, meaning that they are inclined to support the social and emotional needs of each other. Men tend to be more task-oriented. Relatedly, women are more relationship-oriented, men more goal-oriented. Women are generally more concerned about connections with others and closeness. Men are generally more concerned about status and power. Women are more likely to value similarities with other people. Men are more likely to value how they are different from others. The conversational goal of women tend to focus on maintaining the interaction. Men tend to focus on the transmission of information. Research suggests that gender does matter. With regard to physicians' interruptions of the patient, interruptions appear to lower patient satisfaction when the interrupting doctor and patient are both men. However, a female doctor's interruptions seems to facilitate patient satisfaction when the patient is another woman. It has been suggested that a male patient may perceive the male doctor's interruptions as undermining the patient's own power and status, whereas a female patient may perceive her female doctor's interruption as an effort to make a connection. In another study, patients were more satisfied with a female doctor who communicated in the female style. This includes lots of eye gaze, closer interpersonal distance, and a softer tone of voice. In contrast, patients were more satisfied with a male doctor who used the stereotypical male style, which includes greater interpersonal distance and a louder voice. Most studies have focused on the effects of nonverbal behavior on one proximal outcome, patient satisfaction with the medical visit. We badly need research that links physician behaviors to more intermediate outcomes and health outcomes. Such studies are rare. However, I will mention one study that found that physicians who use more eye gaze were more likely to see emotional distress in their patients. This could lead to better quality care. In a different study, it was found that surgeons who used a dominant tone of voice are more likely to have been sued for malpractice than physicians who use a softer tone. These studies suggest that nonverbal behaviors have effects that go beyond patient satisfaction. What about the patient's nonverbal behaviors? This is also an understudied topic. We do know that patients' nonverbal behaviors affect and are affected by physician nonverbal behaviors. One study found that when a doctor indicates through nonverbal behaviors a desire to be affiliative, that is, to have a close connection with us, we as patients tend to mimic those same behaviors. This is called reciprocity. The same study found that when a doctor behaves in a dominant manner, for example, by dominating talk time, we as patients share a tendency to use fewer dominance behaviors. This is called complementarity. Much more research is needed on these relational nonverbal patterns and how they affect patients' health outcomes.